Hi, I'm anesthesiologist Dr. Gayatri Ramesh. Today, let's see how our patients can be treated for the diabetic foot ulcers without any hesitation or any pain. The grade 2 heel and the first metatarsal are common areas for pressure sores and ulcers. Surgical debridement of the same for emergency purposes can be done under ankle block. Let's see the nerves to be blocked for debriding this grade 2 ulcer. The entire foot can be anesthetized by blocking the sciatic and saphenous nerves in the thigh. However, this can lead to motor blockade, which is not preferable for a daycare procedure. Hence, we can block the nerves supplying the foot distally at the level of ankle. The saphenous nerve, which is a branch of the femoral nerve, supplies the foot medially and runs along the great saphenous vein behind the medial malleolus. Rest of the foot is supplied by the sciatic nerve, which divides into common peroneal nerve and the tibial nerve in thigh. The tibial nerve gives off a medial sural cutaneous nerve which communicates with the sural communicating branch from common peroneal nerve, forming the sural nerve which supplies the lateral side of the foot. The common peroneal nerve further divides into superficial and deep branches. The superficial peroneal nerve runs between the extensor digitorum and the extensor hallucis longus, superior to the extensor retinaculum, and supplies the dorsum of the foot. While the deep peroneal nerve runs along the tibial artery, which continues as the dorsalis pedis artery beneath the extensor retinaculum and supplies the first web. The tibial nerve runs between the flexor digitorum longus and flexor hallucis longus along with the posterior tibial artery and vein. Behind the medial malleolus, it divides into medial and lateral plantar nerves which supplies the ventral aspect of the foot. To debride this grade 2 ulcer, we blocked just the tibial nerve, the superficial peroneal nerve and the deep peroneal nerve at the level of ankle. First, we are blocking the tibial nerve behind the medial malleolus by an out-of-plane technique. We are scanning the nerve behind the medial malleolus and we can identify the posterior tibial artery and the vein. The tibial nerve lies beneath it. We can see both the components of the tibial nerve, that is the medial and lateral plantar nerve. Here 5 to 7 ml of local anesthetic, either 0.75% ropivacaine or 0.5% bupivacaine can be given to block this nerve. Next, we place the probe between the medial and lateral malleolus anteriorly, identifying the dorsalis pedis artery pulsatile beneath the extensor retinaculum. The deep peroneal nerve lies adjacent to it. This can be blocked by an in-plane technique with 5 to 7 ml of local anesthetic. Careful aspiration before injecting the drug is essential, especially when close to a vascular structure. Superficial peroneal nerve can be traced further up in the distal leg. The probe is placed in the leg anteriorly to identify the extensor muscles, and the nerve can be identified between the extensor hallucis longus and extensor digitorum longus. So these are the two muscles, and the nerve can be seen in the intermuscular plane. Again, we are following an in-plane technique to block this nerve and depositing 5 to 7 ml of local anesthetic. So in total, we can use around 15 ml of local anesthetic to block all three nerves under ultrasound guidance, and this will give a dense anesthetic blockade around the first toe and the first web space.